webinar. The title is all about medical insurers and the 13 steps of the medical billing and coding process. My name is Mary Ann Hodorowitz, hard last name, I married it. I'm a registered dietitian nutritionist. I have my MBA with a focus on marketing from Loyola University in downtown Chicago. And I'm a certified diabetes care and education specialist and a certified endocrinology coder. Kind of a weird combination with that CEC. How I got that was I was on faculty for what was then called the Johnson & Johnson Diabetes Institute, and we would go live to California and teach diabetes educators live. And I was teaching all about billing and coding, and they asked me to get that credential, which I did. And it wasn't all that difficult, but I'm glad I did it. So there's me, and let's get going. Here's my disclaimer. Now, what this says is that this is not legal information. This is informational and educational only. And to check with, CMS, the Centers for Medicare and Medicaid Services, private healthcare insurance companies, and other professional associations for correct and accurate information, because coding and billing information changes all the time. And health insurers change their rules and regulations all the time. Okay, let's skip the learning objective. Let's go to provider credentialing. Okay, here we go. This is a big key to your revenue cycle success. So what is provider credentialing? It's a process by which providers like physicians, nurse practitioners, even dietitians enter into some kind of an arrangement or agreement with a health insurance company like Medicare, Medicaid, Blue Cross Blue Shield, United Healthcare, in order to furnish medical services and to their subscribers of the insurance company and be paid. So it's not just individual human beings that get credentialed. It's also hospitals, private practices, large healthcare facilities. So not just individual human beings. But it's the very first and most important step in implementing your revenue cycle. So we're going to talk about what it is a little bit. So even when providers know which insurance companies they want to participate with, they have to get credentialed, and it's very time-consuming and a frustrating process. That is why many healthcare organizations outsource this crucial step, because they don't want to be involved in it because it's so tedious and long-winded. So what is it? It's a process of verifying. I'm just say to provider, I'm just going to say Dr. Miller. Dr. Miller's qualifications to ensure that he can provide quality medical care to his patients. Let's say a hospital is getting credentialed. Again, is verifying that they have a valid license, that they're following state and national laws. So the health insurance company is going to examine and review the credentials of Dr. Miller and make sure that his credentials meet a set of educational or occupational criteria and that Dr. Miller is licensed in his field. Now, most health insurance companies require credentialing, including Medicare, Medicaid, and all the commercial plans, and again, as well as hospitals, surgery centers, and private practices. So again, strict credentialing was required by hospitals and managed care accreditation bodies, and it's not one and done. Once you're credentialed, you have to go through it periodically because things change periodically. You may lose your license. You may have a malpractice suit against you. You may lose your credentials. And so periodically, you have to go through the credentialing all over again. And that's why it makes it so tedious. Okay, so the insurance company is going to verify all of Dr. Miller's documents to ensure they're valid and current. And this will include his medical license, his malpractice insurance, and the Drug Enforcement Agency if he's got any charges against him with drugs, his medical school information. For me particularly, I'm credentialed with Medicare as a dietitian to do medical nutrition therapy. And again, they needed to know all my where I went to school and how I got my RDN. His internship, his residency, his fellowship information, his board certifications, and his CV. So it's a lot of documents you have to submit. So if providers wish to bill an insurance company as an in-network provider, they have to undergo the credentialing process. You can't get out of it. You can't ignore it. And so if you're in a practice like a hospital, a surgery center, a private practice, once the organization is credentialed, then the organization can bill the payer directly. So many insurance companies offer providers other incentives to become credentialed, such as referrals, preferential reimbursement rates, and inclusion in their website directories of Dr. Miller and nurse practitioner Nancy Smith, so that their subscribers, consumers, can find the providers easily as a participating provider in a specific specialty. Now, provider enrollment and insurance credentialing for government health programs such as Medicare, Medicaid, and TRICARE is different. That's different. These programs have their own standardized forms that must be accurately filled out. So even though you get credentialed with Blue Cross Blue Shield and you fill out a standardized form for the Blues and United Healthcare, it's going to be totally different for Medicare, Medicaid, and TRICARE. TRICARE is the insurance company for the military. And when you fill out the Medicare forms to get credentialed, they are sent to the your Medicare Administrative Contractor, or MAC, who handles the administrative duties for your program in your own jurisdiction. I think there's 13 MACs in the United States, and it's like 6 or 7 states in each jurisdiction, and you have to send that credentialing paperwork into your own MAC. Oops, sorry. So because this is a time-consuming and frustrating process, and it has to be done periodically, many payers and many providers and healthcare organizations are turning to what they call the CAQH route to credential and enroll medical providers. CAQH stands for Council on Affordable Quality Healthcare, and it's a nonprofit alliance of health plans and trade associations, and it's like a repository of all the credentialing paperwork and databases. So you only have to do a one-time paperwork through CAQH, and it's housed in their repository. And so you don't have to do it over and over again with the Blues and United Healthcare and Cigna and Aetna. You do it one time with CAQH, and you take it out of there to get yourself credentialed with the other payers. So the CAQH solutions, and it really is a solution, helps to promote quality interactions between healthcare plans, providers, and other stakeholders, reduces costs and frustrations associated with healthcare administration. And like I said, it's a central repository. You only have to do one application, and it's housed in the CAQH website. So it's a standardized credentialing application. You only have to submit one application to one source, CAQH. You update it quarterly, and when you go to a credential with a new insurance company, you just pull it out of the CAQH repository. So just bear that in mind. Okay, how do you get that application? Here's the URL on this slide, www.caqh.org, and everything you need to know is right there. But remember, in red at the bottom, Medicare and Medicaid, they're not going to accept the CAQH standardized form. You still have to fill out their own credentialing applications. Okay. Now, CAQH has what they call a Universal Provider Database, or UPD, and it's the industry standard for collecting provider data using credentialing, claims processing, quality assurance, emergency response, and member services such as directories, referrals, and more. Okay, so the UPD reduces duplicate paperwork and all the dollars that are spent in credentialing. And right now, there's over 650,000 physicians and other healthcare professionals in that database, as well as 400 participating health plans, hospitals, and healthcare organizations. So just bear that in mind if you have to get credentialed or your organization has to get credentialed. And it can, even though you go through CAQH, it requires time and patience. It can take about 6 months from start to finish, including if you do it through Medicare, Medicaid, and TRICARE. So you got to be patient, and you got to be diligent in maintaining your contact information, update your status, and monitor the process. Okay, I think we said enough about provider credentialing. Okay, now, many insurance companies split credentialing actually into 2 parts. The first part is the credentialing that we just talked about to ensure that Dr. Miller has the right qualifications to provide quality medical care, all kinds of documents he has to submit. And then there's a contracting step. Let's talk about that. Okay. The contracting step at the very bottom, the fourth bullet point, that's where the healthcare organization like Aetna Blue Cross will issue Dr. Miller a participating provider agreement that defines the terms of the participation. Like, what is this reimbursement going to be? What are the medical services that are covered? So it's basically the contract, how much he's going to get paid for and what he's going to get paid for. Okay, let's switch gears a little bit now and talk about how health insurance works. So most health plans have a few basic similarities, okay, but they can be different. Most insurance plans require that the subscribers pay a premium or a subscription fee, either monthly or annually, and most plans have deductibles, and that's the amount of money that the patient pays first. After the deductible is paid, then the health insurance will pay their part of the cost of the medical service. You probably know this already. So patients can also have co-payments besides deductibles, and co-payments are a little bit different. We'll talk about that in a minute. But understand the third bullet point, that the rules of third-party payers supersede what you want to do. So if you're working in a hospital or a private practice and you want your own way of billing and you want your own reimbursement to apply, your own fees and get reimbursed, that's not how it works. The third-party payer, the insurance company, is calling the shots. And I always say insurers rules rule. That's the bottom line. You can't fight City Hall when it comes to insurance companies. So again, patients may have a copay or co-insurance arrangement. Copay or co-insurance is pretty much the same thing. A copay is a small fixed sum that must be paid before any medical services are rendered. Now, the copay does not count against the patient's deductible. It's separate and distinct. So the copay or co-insurance divides responsibility for payment by percentages. The co-insurance is listed with the payer's portion listed first and then the patient's. Let's look at the example at the bottom. So let's say the patient receives a $300 procedure and the insurance says that's an 80-20 co-insurance agreement. So the patient's going to owe 20%, that's the last percent, and that's going to be $60, and the insurance company is going to pay the 80% of the $300. Okay, so always remember that health insurance requires that providers who are billing for these services are providers that actually render the care. So if Dr. Miller rendered the care, he's the one that his name is going to go on the claim. You cannot substitute provider A for provider B, except if the insurance allows billing incident to physician services. What does that mean? And not all insurance companies accept incident to physician services billing. It means that I can give you one example. With Medicare has a benefit called the Intensive Behavioral Therapy for Obesity benefit. We call it IBT. And nurses, dietitians, all kinds of healthcare, non-physician healthcare professionals can furnish the IBT benefit, but only MDs and DOs can bill Medicare for it. So that billing is done incident to physician services, where Dr. Miller orders the IBT benefit and one of his staff members furnishes it, but Dr. Miller bills for it. The staff member is furnishing it incident to physician services. But again, the insurance company has to approve that, whether a staff member can actually furnish the service and the credential provider can bill for it. Before you do that, check with the insurance company to see if that's permitted, okay? And there has to be documentation to support the services billed. Always, always, always. If there's no documentation by the provider or the staff member, don't even submit the claim. Because if you're audited and you don't have the proper documentation in the medical record, that's going to be big trouble. And health insurances have written policies about coverage for services, so you have to know each of their policies for the coverage of the services you're billing. Now, most claims are typically required to be submitted electronically, and payments are usually accepted electronically, and that's good news. That's really good news. Okay, let's look at the types of health insurance companies. The first one is called Indemnity, and this is the most basic and straightforward kind of insurance in which the patient pays a premium to the insurance company, And the patient likely has a deductible and a copay or coinsurance, like 80, 20, 90, 10. But patients have no restrictions on which providers they can see. They can go to any provider in any network, and they're still going to get the same kind of coverage. But because they have no restrictions on providers they can see, these indemnity plans are typically much more expensive than managed care options. Okay, let's look at managed care organizations, MCOs. Okay, they exist to reduce the cost of healthcare, increase efficacy or effectiveness of health services through several means. And one of the ways they do that is they limit the providers and the facilities that patients may see to a specific network of doctors and facilities. They have fixed costs that are lower than most indemnity plans, but they restrict the options patients have or where they can go get treatment. There's three types of MCOs: HMOs, POS plans, and PPOs. Let's look at the three of them. A health maintenance organization and HMO, they have the lowest premiums, but they have a really strict network of providers that you can see. And if you go outside of that network, like you want to see Dr. Miller, but he's not in that network, you're going to pay a lot more money for that medical care that you got for Dr. Miller, who's outside of that network. They're the cheapest MCO, but they're the least flexible. And if you want to see a specialist and you're seeing, let's say the doctor is in the network and you want to see a dermatologist, if you want your care paid for by the dermatologist, your primary care physician in the HMO has to refer you to the dermatologist. They're called the gatekeepers. So your patients often need to be referred to a specialist by the primary care physician's gatekeeper who's in the HMO. So very restrictive, but they got the lowest premiums. Point of service plan, it's similar to an HMO, but there's a wider network of providers that you're allowed to go to, and you're allowed to go out of network without that referral out of network. Many of these POS plans are tiered, so if the patient pays more if they see a specialist out of network. Again, there's these tierings of networks, and certain tiers you pay more, certain tiers you do not. But the insurance company is going to pay less if they are referred to a specialist by an in-network PCP. PPOs, Preferred Provider Organizations. This is coming up as the most common MCO. PPOs, you can see any doctor, physician, or other provider. You can go to any facility, but you pay less if you see a provider within the PPO network. But if you go outside the PPO network, you're generally not going to be penalized. But that's because you're not going to be penalized with how much is paid, you do pay a higher premium. And so it gives you more flexibility for providers you can see and healthcare facilities you can go to, but the cost of that is a higher premium. Okay, what is Medicaid? It's a joint state and federal healthcare program that provides care to persons who might not otherwise be able to afford it. So Medicaid provides coverage to low-income families and individuals, disabled individuals, and certain elderly persons. Okay, now a person's eligibility for Medicaid varies by state, but there's some relatively common baseline criteria, and that's adults with children earning less than a certain income level. But again, this income amount varies by state and number of children. Another criteria can be individuals earning up to 133% of the poverty line, and that's a provision that's part of the Affordable Care Act. But again, just be aware that every Medicaid plan is different in every state in the country, and they all have different coverage criteria. Okay, so if individuals are earning slightly more than the minimum threshold, like more than 133% of the poverty line, they still may qualify for Medicaid if they pay an additional premium. A lot of times coverage is for individuals suffering from chronic disabilities, or individuals who receive Social Security may also qualify for Medicaid. Like right now, my mother is in a nursing home, and it's a $9,000 a month fee to be in that nursing home, and Medicaid is paying for that, and this is in Illinois. She converted to Medicaid because here in Illinois, once your total assets go down to $3,000 or less, and that's what happened to my mother, then Medicaid will kick in and pay for the nursing home fees and for her medical expenses. But she also has Medicare. So you can be on Medicaid, which she is for her nursing home expenses, and be on Medicare for her medical expenses. Okay, so here are the 7 basic services generally covered by Medicaid, but again, it could differ by state. Family planning care, prescription drugs, inpatient and outpatient hospital services, pediatric services, mental health care, occupational, speech, and physical therapy, and dental health care, and and related services. I'm sorry, something stuck in my throat. Now, always remember that Medicare is a federal program. Medicaid is a combination of federal and state. And again, regulations and restrictions vary by state. Okay, so I know California, which has the Sweet Success program, their Medicaid plan is called Medi-Cal, and Wisconsin's is called Wisconsin Badger Care. So they have different names. They have their own regulations and restrictions. Okay, let's look at health insurance claim forms. You probably didn't know you were going to get all this information in this webinar. We're not even half done. Okay, now remember, most insurance plans, especially with HIPAA, they want electronic claim forms, and they'll pay you electronically, and they want the claim forms submitted electronically. And that's actually a HIPAA regulation. That's mandated by HIPAA, that most claim transmissions have to be completed electronically, okay? But there are exceptions to that. If a practice has less than 10 employees, they can use manual claims. Like say, for example, I'm an RDN, registered dietitian nutritionist, and I want to have my own practice to do medical nutrition therapy, but it's only me, right? As one employee, then I would be allowed under HIPAA to use a manual claim. I can do it electronically if I want, and a lot of dietitians do, but if I want to do it manually, I can. The other exception is there's a power outage and my claims are time sensitive, then I can submit manually. So those are 2 exceptions. Now there's 2 types of claim forms. They operate similarly to bill payers, but they're not interchangeable. There's the CMS 1500. The electronic title is CMS 1450. Now that's used for private practices, non-institutional healthcare facilities, like Dr. Miller's office or nurse practitioner Nancy Smith's office. The UB04, that's the claim form used by hospitals and only by hospitals. Okay, I shouldn't say only. The UB04 is also used by federally qualified health centers and rural health clinics, institutional healthcare facilities. So this is what the CMS 1500, which is a hospital claim form, this is what the top half looks like. This is what the bottom half, it looks very complicated, doesn't it? But again, once billers and coders get used to this, it's no big deal. But you got to learn how to do it. Okay, here's the UB04. This is what private practices use. This is what the top half looks like. It's not as daunting. And this is what the bottom half looks like. Still looks pretty daunting. Okay, now let's look at denied versus rejected claims. What is the difference? Let's look at that. A rejected claim is not the same as a denied claim. A rejected claim is one that contains some errors, one or more errors, preventing the claim to be processed by the Blues or Aetna or Cigna. The Blues, I'm just going to say Blue Cross Blue Shield, the Blues cannot process the claim because of the error. And the error can be mismatched procedure and ICD-9 codes. So let's say the procedure code was for a hysterectomy. That was a procedure code, but the diagnosis code, the ICD-10 diagnosis code, was hypertension. Well, that's a mismatch. You know, you're billing for hysterectomy, but the diagnosis code was hypertension. So, you know, years ago I had a hysterectomy, but that was for endometriosis. And you're saying, Marianne, you're giving us private healthcare information. I am the owner of healthcare information, and per HIPAA, I can share that information with anyone I want to. Where HIPAA comes in with private healthcare information is me sharing private healthcare information of somebody else, but I can share my own. Okay, the other errors that occur which get a claim rejected is there's a mismatched service with the patient's biological information. So let's say a hysterectomy is billed on a male patient. Well, that's not going to fly. So a rejected claim will be returned to the biller with an explanation, an EOB, an explanation that explains what the error is. And these claims can be corrected and resubmitted. But that's time consuming and that costs money. So what happens with a lot of healthcare organizations is they employ what's called a clearinghouse, and they send all their claims to a clearinghouse where the clearinghouse employs a process called scrubbing. They scrub the claims, looking at them very carefully for any errors to avoid rejected claims. And the end goal for the biller and the clearinghouse is to submit a clean claim every time the first time. Okay, but what about denied claims? Denied claims is not a rejected claim. Denied claims, the payer, like Blue Cross, says, we don't pay for dermatology. You submitted a claim to us for skin tag removal, and we don't pay for that service, so we're going to deny the claim. Okay, it's deemed unpayable because it violated the terms of the payer-patient contract. The Blues doesn't cover dermatology, and I'm just giving that as an example. Or it contains some type of vital error that was only caught after the processing. And again, payers will include an explanation why the claim was denied or rejected and send that back to the biller with a payer report. Again, these claims, denied or rejected, can be appealed. We're going to go through the appeals process at the end, some of the last slides. But what I want to say now about the appeals process, either the healthcare organization or the provider can do the appeal, or the patient himself or herself can do the appeal. But again, that's time consuming and it's costly. So again, you want to make sure the claims are going out clean the first time, because you don't want to go through an appeals process for sure. Okay, let's look at the 13 most common types of medical billing errors. This is important. Upcoding, where the provider intentionally or unintentionally misrepresents the work they performed on the patient. They upcode the patient, and they do that to get more money from the payer. So let's say it was a very simple procedure. Let's say a skin tag was removed from the face, and they upcode that to make it look like the patient had skin cancer. And they put a procedure code down that indicates skin cancer when it was only a skin tag. That's called upcoding. Now that's fraudulent. And if the patient finds that out, that should be noted and reported immediately. And then there's undercoating. It's just the opposite. You put a procedure code down on a claim that's for less than what you actually did. Now, why would anybody do that? Because you're going to get less money. Well, a lot of people, a lot of billers or organizations will do that because they're trying to do a favor for the patient, so the patient doesn't have to pay as much in their copayment or co-insurance. Now, this process is also illegal and counts as a type of fraud. Okay, what's another medical billing error? There's poor documentation by Dr. Miller or by Mary Ann, who's billing for medical nutrition therapy. And let's say I hired a biller to do this for me. And poor documentation is very, very common because medical billers and coders have to look at the documentation in order to generate a claim. And if that documentation is poor, it's illegible, which doesn't happen too much anymore with EMRs, but there's not enough there to actually determine what the service was or what was done with the patient. So poor documentation is not fraudulent, like upcoding or downcoding, but it can negatively affect the claims process because the billers and coders don't know what to bill for. So if the provider has incorrect, illegible, or incomplete documentation of a procedure or patient visit, it's very difficult to do an accurate or complete claim. Or if the documentation is sloppy, even though it's on an EMR, the provider has missed certain required data fields, so then the biller has to contact the provider and ask for more information. Now, what's another medical billing error? There's no explanation of benefits to the denied claim. So the biller gets information from the Blue Cross that says your claim's been denied or rejected, but there's no EOB with it. So the biller doesn't know why it was denied. So then the biller has to contact the insurance company by phone and go through this whole process to find out why it was denied. Incorrect patient information, incorrect sex, name, date of birth, insurance identification number, incorrect provider information. Now remember, the provider has to be credentialed with the insurance company. So say it was Dr. Miller who did the service, but on the claim, it was Dr. Smith who was listed as providing the service, but Dr. Smith was never credentialed with the insurance company. Incorrect insurance provider information, wrong policy number, wrong address, and again, incorrect codes, incorrect diagnosis codes, procedure codes, revenue codes, and place of service codes. Revenue codes are only used for hospitals. A revenue code indicates what area the service was furnished in. Was it the ER? Was it outpatient? Was it inpatient? Was it laboratory? Was it mammography? That's what a revenue code is. It's only used for hospital claims. Okay, another common medical billing error, attaching conflicting or confusing modifiers to the HCPCS codes. HCPCS codes are Healthcare Common Procedure Coding System. They're a subset of CPT procedure codes. And like diabetes self-management training, a Medicare benefit uses the HCPCS codes. It always starts with an alphabet, like G0108 and G0109. So a procedure code that starts with an alphabet, like A, B, C, D, E, F, G, is a HCPCS code. And a lot of times, Medicare and private insurance companies do require modifiers to HCPCS codes. Modifiers tells the insurance companies a little bit more about what's going on or has gone on with the service that was rendered. Another Medicare billing error is entering too few or too many digits to the ICD-10 diagnosis code, the procedure code CPT or HCPCS, that's very common, or a mismatched medical code. Again, billing for hysterectomy on a male patient, or leaving out codes altogether for procedures or the diagnosis on the claim form, or duplicate billing. Okay, now let's look at the 13 steps to the medical billing process. So I'll try to keep this as simple as I can. The process of billing an insurance company, also known as a third-party payer, is very difficult to summarize because much of it depends on many variables. So these are the 13 most basic steps, but it's going to depend on the patient's insurance plan. And I really got to emphasize, if their rules for billing supersede what you're going to learn now, you have to follow their rules. Okay, the 13 steps I'm going to go through are common medical billing steps, but if your insurance company you're working with has other steps, you have to follow what the insurance company tells you to do. Again, the insurer's rules rule. Okay, let's look at the 13 steps. Step 1, the first step is to set up your fee schedule. So how much are you charging for your services? Can you have more than one fee schedule? Yes, but it has to be based on set written criteria. So in case you get audited and they see you have a couple different fee schedules, you have to show why that was done, what were the criteria, and was it legitimate? Can you have a sliding fee schedule based on the patient's income? Yes, you can. But again, it has to be consistent. You have to apply it to every patient who meets the criteria, and you have to document how the fee schedule was determined for the patient, and you have to monitor that on a regular basis, and you have to use it for all patients who meet the criteria. So be very careful if you have a sliding fee schedule, where you're charging less for certain patients and charging more for certain other patients. Make sure that your criteria is well documented, your policies and procedures are well documented, and you're using the same set of criteria for all the patients. Okay, so you say, well, how do I set up a fee schedule, even though I only have one? A lot of healthcare organizations and providers will look to the Medicare fee schedule first to determine their fees. First of all, why? Because Medicare publishes their fees on the internet, on cms.gov, and that's why and commercial insurance plans like the Blues, Aetna, Cigna will also go to the Medicare fee schedule as the basis for how much they're going to pay you. Okay. Now, people say, well, do the insurance commercial plans, that when they set up what they're going to pay you, does it match Medicare? What history has taught us is that the commercial plans pay anywhere from 85 to 150% of the Medicare fee schedule. So if Medicare is paying $100 for a procedure, the Blues may pay 85% of that, or they could pay 150% of that. It just depends. You can use the Medicaid fee schedule to determine yours, but Medicaid doesn't pay a whole lot of money. So it's probably not a good idea to use the Medicaid fee schedule because you're going to leave money on the table. They don't pay a whole lot. Okay, let's look at step 2, and that's patient registration and the verification process. So let's say the patient calls, let's say Martha is our patient, like in Martha Stewart. She calls to set up her first visit, her appointment. So the patient, we have to pre-register the patient for the appointment. You have to validate who they are, what their coverage is. Do they have Medicare, Medicaid, or a private insurance plan? What their copay is going to be, because that has to be paid when they walk in the door. And if the service is considered self-pay, they don't have insurance. Okay, and that self-pay, that's going to work for scheduled patients and walk-ins. But if if Martha has seen a provider before, that patient's information is already on file. So the patient only has to explain the reason for the visit. But if the patient is new, the patient's going to have to provide that personal insurance information to the provider to ensure that they are eligible to receive services from the provider per their insurance plan. And I'm sure you've all gone through that. You call to make an appointment. I know I've done this a million times, and they say, well, what insurance do you have? And I'm on Medicare. Well, I have Medicare Part A and Part B. Okay, give me your Part A Medicare number. Give me your Part B Medicare number. Do you have any secondary insurance? Yes, I've got Blue Cross Blue Shield of Illinois. Well, give me that number. Give me the group number. So you have to go through all of that over and over and over again. That's that patient registration and verification process. Okay, step 3, establishment of financial responsibility for the visit and ABNs. Let's look at that. ABN stands for Advanced Beneficiary Notice. Okay, so once the provider has all the pertinent info from the patient, the provider then determines if the service is covered under the patient's insurance plan. If it's not covered under the insurance plan, like say for me, I have Medicare. Medicare is not going to pay for dental work. I just went to the dentist last week. Medicare doesn't pay for dental work, okay? That's excluded from Medicare, completely excluded. Medicare never pays for dental work. So with Medicare, when a benefit is, and this is going to come up in a couple slides, when a Medicare benefit is excluded from payment by the Medicare system, you don't have to give the Medicare beneficiary an ABN. You only have to give the Medicare beneficiary an advance notice that Medicare may not pay if there's something about how you're furnishing the benefit where they may not pay. We'll go over this in a few more minutes. So again, insurance coverage differs dramatically among insurance companies and plans. So the provider has to check with each patient's coverage in order to assign the bill correctly. Certain insurance plans do not cover certain services or prescription meds, like Medicare doesn't cover dental. Okay, so when I went to this dentist the first time, they gave me a financial responsibility statement. It wasn't an ABN, but it was a financial responsibility statement because I had Blue Cross as my secondary. And I basically had to sign it that says, I know that, actually it was an ABN, that says, Medicare is not going to pay for this, and you're going to be responsible for, and they had to put the amount in there, for $300 for the work you're going to have. Now, ABNs are not typically used by commercial insurance companies. They only apply to patients enrolled directly with Medicare, not patients who have coverage through a Medicare product like a Medicare Advantage plan or a private health insurance company. An ABN is basically a Medicare waiver of liability that providers are required to give a Medicare patient for services provided that may not be covered or not considered medically necessary. So again, like my dental work, I did get an ABN from the dentist that says Medicare is not going to cover this, and you're going to be responsible for the $300 bill. And then at the bottom it says, yes, I want the service and I will pay the $300, or no, I don't want it, and I walk out of the office. So again, ABNs are used by Medicare when the service provided is not going to be reimbursed by Medicare. Now, but there's a little caveat to that. If the service is completely excluded from the Medicare system, you're not required to give the ABN. If like dental care or vision care, you have to give the ABN when it's the way you provided the service may not be covered. So what was an example? The Medicare Diabetes Self-Management Training Benefit, DSMT, Diabetes Self-Management Training, Medicare pays for 10 hours in the first calendar year. But let's say you're going to give the 11th hour or the 12th hour. Now that is a covered benefit. It's not an excluded benefit, it's a covered benefit. But the patient wants the 11th hour, the 12th hour. Remember, they only pay for 10. That's when the ABN would be used, because the provider has to say, Medicare doesn't pay for hours over 10, and I'm going to be billing for the 11, 12, 13 hour. Then an ABN would be required. But again, for dental care, vision care, that's excluded from Medicare, the ABN would not be required. Okay? Now, the ABN, you can actually access that at this URL at the bottom of this slide, so you can see what it actually looks like. Okay, examples of services that require an ABN, the visual field exam for an ophthalmologist, pelvic exam by a primary care provider, an echocardiogram. These should be covered if medically necessary. But again, if medically necessary. But if it's not medically necessary and the provider knows that, then the ABN should be given. And there's your diabetes self-management training benefit, hours beyond the 10. Again, as I mentioned before verbally, ABNs do not apply to services that are specifically excluded from coverage. So it's like an eye exam or a dental workup. Okay, you're not required to give ABNs for these types of excluded services. You can if you want. You can if you want, but you're not required by Medicare, but you can if you want. Okay, and that would be voluntary, where you voluntarily want to give the ABN for excluded services, but Medicare doesn't require you to, but it's voluntary. Okay, so when you, there's procedures that are provided that require an ABN must be submitted with one of the following 4 Medicare providers. Okay, so when you're submitting a claim to Medicare, okay, there's one of 4 modifiers that have to be attached to the procedure code. Modifiers are only used on a procedure code. So what is the GA modifier? The GA modifier on the procedure code, like G0108, which is individual diabetes self-management training, and I put G0108-GA. What that tells Medicare on the claim is that the ABN, the waiver of liability statement, the ABN was issued as required by Medicare. It is on file, and it allows the provider to bill the patient if not covered by Medicare. So my patient said, yes, I want the 11th, 12th, and 13th hour, and yes, I'll agree to pay the $80, and he signed the ABN and said, yes, I agree. That's the GA modifier. What is the GX modifier? That means the notice of liability was issued, but it was voluntary. It was voluntary. It wasn't required by Medicare. The service was excluded for Medicare payment, but the organization voluntarily said, I still want to give it to my Medicare beneficiary, even though it's not required. Okay, so this is to report to Medicare that the modifier, that a voluntary ABN was issued for services that are not covered, but it was voluntary. What is the GY modifier? The ABN, what's called notice of liability, was not issued, okay, because it was not required under payer policy. And why would you do a GA modifier? You're basically telling Medicare, I know that the dental exam is not covered. I know that the eye exam is not covered. I'm not stupid for billing. So why would the practice want a denial? So they can send that a claim then to my supplemental insurance, which is Blue Cross Blue Shield of Illinois. Okay, they want to see that denial so they can resubmit the claim for the dental work and the eye exam with the denial to Blue Cross Blue Shield, because Blue Cross is going to want to see the Medicare denial first before they will pay for my dental exam or my eye exam. Hope this is making sense. Okay, what is the Gz modifier? You're probably right now you're thinking, oh my God, Marianne, this is like, you've lost me like 30 minutes ago. I hope I didn't lose you, but you've got the deck, so this is good. What is the Gz modifier on a procedure code? The item of the service is expected to be denied as not reasonable and necessary. okay? When an ABN is required but not obtained, this modifier should be applied, okay? So you expected it to not be paid, so you put on the Gz modifier. So again, an ABN can be voluntary, and there's a specific modifier when you give it when it's voluntary, and it's a courtesy to the patient so that the patient can make an informed decision whether he really wants that service because he's going to be paying out of pocket. Okay. Now, some commercial non-Medicare plans are starting to require healthcare providers to obtain ABNs when the insurance plan does not cover a procedure or a service. So a lot of private commercial payers are saying, we want to do the same thing Medicare is doing. So if we don't cover a specific service, we want you to give our subscriber, our Blue Cross Blue Shield patient, a similar financial responsibility similar to an ABN. So again, insurers rule. You have to find out if the commercial plan you're billing requires a financial responsibility statement similar to a Medicare ABN. So verify that. So what's recommended is that healthcare organizations, hospitals, private practices create clear and convenient strategies to collect patient financial responsibilities, not only support the organization's revenue cycle, but to drive patient satisfaction. Patients don't like any big surprises for bills that they didn't anticipate. So they go to an eye doctor and it's going to be $500 and they didn't get a financial responsibility statement, they didn't get an ABN, they thought it was going to be covered, and all of a sudden they get a bill in the mail for $500. They are not going to be happy campers, and they may never go back to that eye doctor again. And you don't want that, right? So they say that healthcare organizations have to start looking at retail style strategies, incorporate retail style strategies into their patient bill pay protocols. So have better price transparency. I know the one hospital I go to, I live in Palos Heights, Illinois, Palos Hospital. When I walk into the outpatient lab area where I go for blood work a lot, it has the prices of all the lab work posted on the wall. It has the prices for x-rays and ultrasounds and MRIs, so that if I do get an ABN, the prices are listed, and do I really want to have the service in the end? I remember I went for blood work, oh God, it was about a month ago, and they said to me, Mary Ann, you see the price up there? It's going to be like $800, and Medicare is not going to pay for this. And I said, yeah, but my doctor, I have to have it for this problem I'm having medically. And they said, well, we just want you to know that Medicare is not going to cover this. And so they handed me voluntarily an ABN, and I did sign it, and I got a bill at home for $800. Okay, the other thing that healthcare organizations are doing is they're implementing payment plans to help patients budget for their treatments. So if I saw that I was going to have to pay $800, I'd say, gee, am I going to pay for that, or do I need that $800 to pay for life necessities for my family? Well, one hospital I worked for in the outpatient diabetes clinic, this would happen a lot, and the hospital had payment plans for patients who couldn't afford that kind of big bill, and they would meet with these people in that department, and they would come up with a payment plan, like X number of dollars every month, so that the patient wasn't caught off guard with a big bill all at one time, and they were on that payment plan that was decided on ahead of time. So for the patient's benefit and yours, use an ABN type of form. Again, Medicare requires that if you expect that the services, there's things you're like that 11th, 12th, and 13th hour of DSMT that you know Medicare is probably going to deny that claim. Make your bill paying electronic and post your fees because your patient is expecting this now. Okay, let's look at the step 4, patient check-in and check-out in creation of a super bill, by a medical biller to a medical coder. Now, there's a lot of confusion between a Medicare biller and a medical coder. That's why I put in blue medical biller and medical coder. Okay, so once a patient, Martha Stewart, checks out, she's there for a visit with Dr. Miller. she's a post-hysterectomy follow-up visit. She checks out, she's checking out. So what happens then? A medical report, what's also called a super bill from Martha's visit, is created by a medical biller. Okay, and that's sent to the medical coders to generate the claim. So the medical coders will look at that medical report, the super bill, and translate everything on it from Martha's visit with Dr. Miller into usable medical codes for the insurance claim. Procedure codes, diagnosis codes, revenue codes if it was hospital, and place of service code. If the patient has no insurance, that super bill or that medical report is used to create an invoice or a bill that's going to be sent to the patient for the patient to pay out of pocket. Whoops, sorry. Okay, so as I mentioned in the second bullet point, medical coders are going to take all that medical information in the medical report from Martha's visit with Dr. Miller, and they have to code it all into a CPT code, a HCPCS code, a revenue code. Revenue codes are only used in hospitals. An ICD-10 diagnosis code. We're no longer on ICD-9. A place of service code. Was it hospital? Was it a private practice? Was it a surgery center? Was it an FQHC, an RHC, and the type of bill? Okay. So medical coders, they analyze the patient's medical records, and the medical record was done by the medical biller, and they assign all the right codes into a chargeable service. Okay. Now, sometimes they do have to consult with doctors and nursing staff if they need to clarify information or what's on that medical record. Because again, if the documentation by Dr. Miller was bad, he didn't give enough documentation, so the medical biller didn't get good documentation. Then the medical coder is like, I got to go back to Dr. Miller or the nursing staff to get the information I need. Okay, so medical billers use instructions provided by medical coders to file insurance claims. So the medical coders are not filing insurance claims. The medical billers are filing the claims. The coders only code the services, the diagnosis. The medical billers are the ones submitting, actually creating the insurance claims and sending them to the insurance companies. Okay, so remember, each procedure code has a specific financial value. That's why it's very important to get the right procedure code on the claim form. So, if you're billing for medical nutrition therapy and that Medicare pays pretty good for that, you want to make sure you're using the M&T code because it pays very well. You don't want to make a mistake and bill for the IBT for obesity benefit because that doesn't pay as much as medical nutrition therapy. So you got to be very careful what code you're using on those claims. Okay. So medical billers work mostly with patients. They will communicate with patients. They're not only submitting claims, taking that medical report and translating it into a claim and sending the claim to the insurance companies, but if the patient doesn't have that service, if the patient has the type of insurance where that service is not going to be paid for, or they don't have insurance at all, then these medical billers are going to have to work with the patients because the patients are going to get a bill, okay? And they're going to be communicating with patients. And things don't always go smoothly when they're communicating with patients. But the biller has to act professionally and empathize with the patients who are not always thrilled to discuss costs they never expected to cover. That's why financial responsibility statements are so important. And billers will help patients understand their charges, so they're an integral part of that whole healthcare experience. Medical coders don't work with patients. They're just coding what's on that medical report. Procedure codes, revenue codes, diagnosis codes. Okay, so coders. They analyze patients' medical records that's coming from the medical biller and assign the right codes to every chargeable service. Okay, consults, tests, treatments, supplies, and medications. Do they sometimes consult with doctors and clinical staff? Yes, to verify information, because the medical report that the biller gave them is only as good as the documentation by Dr. Miller. If Dr. Miller's documentation for that visit was poor, then that medical report is going to be poor. And so the coders may have to liaison with doctors and clinical staff. Okay? And at the last bullet point, the medical coders really have to work with they have to update themselves all the time with standardized codes from government resource books. Every year, a new CPT manual comes out, a new HCPCS manual, a new ICD-9, ICD-10 diagnosis codes, and you have to keep up with that if you're a medical coder. Okay, as I mentioned before, medical billers, they create medical reports after the patient visit. They have to go into the EMR, and this is all done electronically on the EMR. They have to generate a medical report, which is also called a super bill, and send that to the medical coders so that the coders can then generate patient invoices or claims. Okay, so the second bullet point. So again, the medical billers are giving the coders all the information they need to file insurance claims or to create bills sent to the patient without insurance. Okay, and they follow up on any issues until the bills are paid or closed. So if the patient gets a bill because they don't have insurance, medical billers are also responsible for following up to make sure that the patient does pay that bill. So this can be tedious because a lot of times patients don't want to pay those bills, right? So if claims are denied by the insurance company, the medical billers can go through an appeals process. Something I want to point out here, the facility or the organization that's submitting the claims, they can do the appeals process. If the claim is denied or rejected, the medical billers can start the appeals process. But the patient can also do the appeals process. The organization can do the appeals. The patient can do their own appeal. It can go both ways. If the patient, it helps if both do it, the organization and the patient, because if the patient's doing it, that's a subscriber to the insurance plan, and the insurance plan doesn't want to lose subscribers. So they're going to pay attention when a patient does the appeals process herself. Okay? And then the medical biller is also posting payments to the patient's accounts. Okay. So as I mentioned before, medical billers work with patients, medical coders don't. Medical coders are working behind the scenes in collaborations with the doctors and billers and the other staff, but medical billers are at the forefront communicating with patients. Okay. What's step number 5? The medical coder generates a paper or an e-claim, electronic claim. So like I mentioned before, the coder takes the medical report as a super bill from the biller and puts it into a paper claim or into the proper practice management or billing software. Because again, most claims are submitted now electronically. If you have more than 10 employees per HIPAA, it has to be done electronically. Okay? Okay, so medical billers also include the cost of procedures on the insurance claim. So once the biller has created a medical report, the coder ensures that the claim meets the standards of compliance both for coding and format. Okay, let's look at step number 6. As I mentioned before, the medical coder is checking for coding and billing compliance. Claims have to have provider info listed as a national provider index or national provider number, NPI number. If patients are direct billed for services, an invoice for the appointment is created based on the patient's super bill or medical report. And again, the coder is going to send then, the coder and the biller will work together to send that bill directly to the patient. Okay. The medical coder has to ensure that the bill meets standards of billing compliance. And there's guidelines, I'm sorry, I misspelled, put an F before guidelines. Standards of billing compliance is done by HIPAA and the Office of the Inspector General. The OIG governs standards for Medicare and Medicaid. Okay, so coders have a lot of responsibility and they're working behind the scenes. The accuracy of the coding process is, again, generally left up to the medical coder. But remember, the medical biller also reviews procedure codes and all other codes to ensure a correct, so they work together. They both work together. The medical biller is the first one to generate a medical report after the patient visit. It's called a super bill. That goes to the coder. The coder codes everything on the claim, and then the medical biller is going to check those claims one more time from his or her perspective to ensure that there is the correct clean claim before the biller sends it out to the insurance company. So they really do both work together, but they have different responsibilities. Okay, while claims can vary in format, we got the UBO, the CMS, the UBO4 claim, the CMS 1500, but there's certain basic types of information still have to be on both of the claim forms. Patient demographic info, medical history, procedures performed, and again, each procedure is paired with a diagnosis code. So if the patient came in with a follow-up after a heart attack, there could be different procedure codes on what Dr. Miller did with that patient, and each procedure code has to be paired with the right diagnosis code. So we did a procedure for hypertension. That has to be paired with a hypertension diagnosis code. He did a procedure to check on the patient's atrial fibrillation, and that procedure code has to be paired with the right diagnosis code for AFib. Okay, and then on these claim forms, they have to put how much they're charging. What is the fee that they're charging for the procedures that were rendered? Okay, and again, the claims for the provider's name is on the claim form, like Dr. Miller, and his NPI number has to go on that claim form. And then a lot of claims also require a place of service code, which details what type of facility the medical services were performed in. Here are some typical place of service codes. 01 is pharmacy, 02 is telehealth, 03 is school. You can see 04 homeless shelter. Okay, 09 prison correctional facility. 10 is office. That's used a lot for private physician offices. 12 is home. You know, like dietitians can go into a patient's home to do medical nutrition therapy and diabetes self-management training. And so if I did go into a patient's home, on my claim form under place of service, I'd have to put 12, that it was done at the patient's home. Okay? Okay, what's step number 7? Transmit the claims to a clearinghouse. You're like, Marianne, what's a clearinghouse? Okay, remember, you're getting the sense now that a claim can be very difficult because of all the stuff that has to go on a claim, and medical billers are working in conjunction with medical coders, and there's all that correct documentation by Dr. Miller and all the stuff going back and forth. It can be very difficult to get a clean claim. It's called a clean claim to go to the insurance company. And if that claim isn't clean the first time it goes in, it could be denied or rejected. And then to fix that denial or rejected is time consuming and costly. So a lot of organizations, a lot of healthcare organizations will hire what's called a clearinghouse, which is a third-party organization or company that receives and reformats claims from medical billers and transmits them to payers. Because these clearinghouses know exactly how to format a claim for Blue Cross, Aetna, Cigna, United Healthcare. Because remember, insurers rules rule. Every private insurance company has their own way that they want claims submitted, even though there's certain basic rules about procedure codes and ICD-10 diagnosis codes. There still could be funny things that the insurance companies want, and it could be worth it to pay a clearinghouse a small fee to scrub that claim and get it in the right format to send to the commercial payer. Okay, so the clearinghouses really ease the burden of medical billers by taking the info necessary to create a clean claim and placing it into the appropriate form that the insurance company wants. In case of high volume third-party payers like Medicare or Medicaid, what billers usually do is submit the claims directly to the payer electronically. If you're billing Medicare, that's high volume, right? When you open up an electronic claim, as you're filling in all the fields, the data fields, if you get it wrong, you're going to get a pop-up window that tells you you're getting it wrong. So that's a good thing that Medicare does that. So generally on Medicare claims, that doesn't go to a clearinghouse because electronic claims that Medicare gives you, they're building in, they make it kind of dummy proof. They're building in pop-up windows that tell you if you're getting it wrong. okay? So billing electronically, especially Medicare and Medicaid saves time, saves effort, saves money, and significantly reduces human or administrative error in the billing process, especially clearinghouses. But remember, per HIPAA, healthcare entities covered by HIPAA required to submit their claims electronically, except if there's 10 or less employees or you have a power outage and you can't submit it electronically and it's a time-sensitive claim. Okay. Again, manual claims, but this practice has significant drawbacks. There's a high rate of errors because you're not getting pop-up windows like you have on electronic claim. Low level of efficiency. It takes a long time to get the providers to get, takes a long time then to get that claim mailed in and to get the payment back to the provider. Okay, think of it this way. A practice may send out 10 claims to 10 different payers, but each with their own set of guidelines for claim formatting and submission. So instead of having to format each claim specifically for each of these 10 payers, the medical biller can simply send the relevant info to a clearinghouse, which then handles the burden of reformatting those 10 different claims correctly and transmitting those claims to the 10 payers, according to how each payer wants that claim formatted. Okay, what's step number 8? The primary payer sends the report to the provider after the private payer or Medicare is going to say it's called adjudicate, review the claim. That's called adjudication. So the primary payer then sends a report to the provider, to Dr. Miller's office, or to the hospital, or to the medical biller, detailing what and how much of that claim that they're going to pay and why. The report will list the procedures that the payer will cover, the procedures of services not covered by the Blues or Medicare and why, and the amount of money, the amount of reimbursement that the payer decided to pay for each procedure that was listed with the code. Okay? And again, even though you charge certain fees on your initial claim, that doesn't mean the payer is going to pay those fees. Per your contract with the payer, they're only going to pay what the contract says they're going to pay. If the patient has secondary insurance, whatever amount that the payer didn't pay, okay, let's say it was a $300 claim, and the payer only paid $200, okay, then the medical biller is going to take that amount left over and bill it to the patient's secondary insurance to see if they can get the secondary insurance to pay the remainder. Like for me, I have Medicare as my primary, but Blue Cross Blue Shield of Illinois is my secondary. So whatever Medicare doesn't pay, okay, the rest of that money, that another claim automatically gets sent to Blue Cross Blue Shield so they can pay the remainder. That's why I have Blue Cross Blue Shield, to pay what Medicare does not pay. Okay, what's step number 9? Okay, the Medicare biller, again, has to monitor the insurer's adjudication or review or the decision of those claims. Once the claim reaches the payer, it undergoes that adjudication, that review by the payer. The payer evaluates the medical claim and decides whether the claim is accepted, denied, or rejected. And medical billers have to watch for that. And remember, the payer usually has a contract with the provider that stipulates the fees and reimbursement rates for the procedures billed. An accepted claim does not necessarily mean that the payer will pay the entirety of the bill. They're only going to pay what the contract says they're going to pay. A rejected claim means there's some error on the claim, and then the medical biller has to correct that error and resubmit the claim. A denied claim means that service was never under the contract. That service is not covered. The bills for the procedure is not covered on the patient's insurance coverage. Okay. Okay, what is step number 10? The medical biller checks for the adjudication report. They're going to get a report back from Blues, Medicare, Medicaid, Aetna, Cigna to say what was paid, what wasn't paid, denied, accepted, or rejected. Okay, the medical biller is responsible for that. Okay, and if it was denied or rejected, the claim has to be resubmitted, and that's what the medical biller is going to have to do, resubmit the claim. Okay, step number 11. Now, As I mentioned earlier with the appeals process, if the claim is denied and yet the contract says that this service should have been paid for, this was part of the contract, but the insurance company got it wrong. They didn't realize they got it wrong, and they denied payment for that service, even though the contract says they should have paid for it. Two things can happen here. The healthcare facility can go through the appeals process with the insurer to appeal that denial because they know the contract says you should have covered the service. Or they can have the patient appeal the denial. And a lot of times it's both. The healthcare facility, the medical biller will appeal the denial, and they'll ask the patient to also appeal the denial so that it's coming to the insurance company at both angles, from the healthcare organization and from the patient both, appealing the denial. But appeals are long and tedious, so that's why you want to get a clean claim out with every claim the first time. That's why clearinghouses can be so important. Okay, what is step number 12? Okay, the medical biller generates a patient statement or bill. Once the medical biller receives a report from the payer, and the payer's just not going to pay, and the appeals process didn't work by the patient or by the healthcare organization, and again, if the healthcare organization is going to appeal a denied claim, they have to follow the appeals process stipulated by the payer. Okay, you have to find out how the payer wants that appeals process to be forthcoming. You can't make it up yourself. But when it's over and the insurance company says, we're not paying no matter what, you sent the appeals process, the patient did the appeals process, no, we're not going to pay it. Then the medical biller has to send a bill to the patient for payment. And that's called a statement. And they have to say on the statement why the insurer did not pay. And the medical biller may include what's called an EOB. You've probably received them yourself with the patient's bill that says why the insurance company didn't pay, to help kind of ease it, because the patient's going to be like, what? You know, patients get kind of upset. Okay, step number 13. The medical biller has to follow up with the patient payments and make sure that whatever part that the patient had to pay, that the payment really came through. Did the patient really pay his part? What else do they have to follow up on? Like me, Medicare. Whatever Medicare didn't pay, that remainder has to go to Blue Cross Blue Shield of Illinois. The medical biller is going to have to follow up with Blue Cross. Did Blue Cross actually send them the remainder of the payment for what Medicare did not pay? So Medicare billers have a lot of responsibility, as you can somehow see. Okay. And as I mentioned before, they follow up on denied patient payments and how collections are handled. What if the patient has to pay out of pocket and the patient's refusing to pay? Well, that may have to then go to a collection agency, and the medical biller is going to have to facilitate arrangements with the collection agency, and that's not pleasant. So what are the 6 things to do to fix medical billing errors before they happen? Number 1, stay current. Stay current on all the up-to-date billing and coding trends, because it changes every single year. Trust me when I say that. As an endocrinology coder, insurance companies change their billing rules every single year. I can tell you, I work with Medicare a lot. I teach the Medicare rules for the DSMT benefit and the MNT benefit, all the Medicare benefits that relate to dietitians and diabetes educators. And every year they change the rules for all of those Medicare benefits. And it makes me crazy. I like pull my hair out because I've got all my PowerPoint set up and have to change all that. Oh my gosh, it makes me nuts. So you got to stay current. You got to be diligent. Always double check your work when you're creating a claim. That's why billers and coders work together. They double check each other. And you're checking for simple clerical errors like missing digits, misspelled names. Okay, very, very important. Communicate. Billers and coders work together. Okay, it isn't one against the other. They work together. Follow through. When you send a claim to a payer, follow up with a representative working on the claim. Okay? Check for clerical errors. And that's the number 1 to 4% of claims are denied among the 7 major insurance companies because of clerical errors. So that's why sometimes clearinghouses can be a better bet, because they identify those clerical errors and scrub that claim to get rid of those errors. So make sure you don't have clerical errors before those claims go out. And again, the appeal, if your claim is denied, rejected claims mean there's some kind of clerical error, like a hysterectomy on a male patient. But if they just flat out deny your claim and you think that that service should have been covered because it's in your contract that that service is covered, remember, appeals can work both ways. The appeal can be by the healthcare organization or the private practice, or it can be by the patient, or it can be by both. It can be by both. If you're going to have the patient join in on the appeals process, the medical biller will help the patient go through that process. And these couple last slides kind of review that a little bit. This one especially, how to appeal a health insurance claim decision. The patient cannot miss the deadline. There's deadlines for the appeals process. And again, the biller is going to help that patient with that appeals process. Okay. And a lot of times the biller is going to help that patient do that appeal, and the patient's going to have to include an appeal letter. Okay. And the biller can help that patient write that appeal letter. It's got to be kept really straightforward, very matter of fact. If you look at the last bullet point, the patient can say, I am writing about claim number. I received a letter denying my claim for XYZ services for this reason. I would like to appeal this decision. And the biller is going to help the patient with that appeal letter. Okay. And if the patient's doing that appeal letter with the help of the medical biller, he can get the doctors to support him or her. Okay. I actually had to do this myself. My situation was I have really bad osteoarthritis because of my age, and I was told by my Medicare Part D prescription drug plan, I've got Humana, that they would pay for lidocaine patches, 6% lidocaine patches to put on my legs and back for my osteoarthritis pain. It has that in my Humana Part D plan. So my doctor wrote out a script for the lidocaine patches, and Humana wouldn't pay for them. They denied it, and they wanted to charge me like $400 for 30 patches. So I got back to my doctor, and I got my doctor to write a letter to my Humana to say, I'm prescribing this. You need to have it for my patient because she's got bone on bone. And I worked with my doctor, and we got it paid for. So I did get my 30 lidocaine patches. Instead of paying like $300 or $400, I paid like 80 cents per patch. So, but my doctor did help me. Okay, these are my references. But anyway, this was a lot of work going into this PowerPoint deck, but I hope it was worth it for you. It was a labor of love.